Now, today I am going to discuss about the calcium and vitamin D, and I'll, I'll actually discuss some case studies which I had seen in last few 1 or 2 decades. And before I discuss about the case studies, I'll go a little bit about the vitamin D metabolism and the calcium metabolism to give you an idea that how we should look into the cases or in our real life situations when we face a patient with some calcium or vitamin D disorder. Now, we know that the calcium is basically transported in the blood in two forms. One is bound form and another is a free form. So whenever you are asking for a calcium report from the lab, they will always give you the total calcium value. Please remember that they will always give you total calcium value, and as you can see that the 50% of the total calcium is ionized or free, and 50% is basically bound and mostly with albumin. And therefore it is easy to understand that the change in the serum albumin level will have significant impact on the total calcium value. So we know that every 1 gram per gl decrease in the serum albumin value is associated with 0.8 milligram per gl reduction in the serum calcium. So whenever you are looking into the calcium value, please remember that you have to get some idea about the serum albumin value as well, and you can use this formula of corrected calcium which take consideration of the serum albumin value as well. So this is the first point we have to remember. Now, calcium in our blood is basically under very active control, and one of the most important factor which is responsible for the regulation of the calcium balance is the absorption of the calcium by the intestine. And this absorption of the calcium is mediated through the active vitamin D. So vitamin D, its role in the calcium metabolism is mostly at the level of the intestine. The second is that the calcium is excreted in the urine if the serum level goes beyond 10 milligram per dl. So daily 24-hour calcium excretion is very small, roughly around 100 milligram. You can say it may ranges from 50 to 150 milligram per day. The third point which has got a significant contribution of the serum calcium level is the bone. We have a huge skeletal reserve of calcium, roughly around 1 kg, and continuously there is resorption at the level of the bone, and there is a constant inhibition of the resorption at the level of the bone. So these two continuously going on and is basically influenced by two important hormones, parathyroid and calcitonin. And bone remodeling, which is basically occurs by the two important cell, osteoblast and osteoclast, they constantly either build or destroy the bone. So this remodeling process is a constant affair. So these are the few important area or few important points and factor which actually influence the serum level of the calcium. Now calcium we every day take roughly around 1000 milligram. So therefore whenever you are giving a calcium replacement, you should give roughly around 1000 milligram per day. And if you look into the guidelines, almost all guidelines has said that your replacement dose should be around 1000 milligram. It may vary from guideline to guideline, maybe from 800 milligram to 1200 milligram, but roughly around 1000 milligram in most of the guideline. And that is because the fact our everyday intake of calcium is roughly around 1000 milligram. And out of this 1000 milligram, the 900 milligram comes into the urine, 100 milligram comes into the urine, and the balance is maintained. But every day there is 350 milligram of calcium enters into the extracellular fluid, and 250 milligram comes out with the secretion. And bone is not a very inert organ. Every day 500 milligram goes in and 500 milligram goes out, and so that the balance is maintained, and every day we expect 100 milligram of calcium excretion through the kidney. So this area of the bone resorption and the absorption or modeling occurs through osteoblast and osteoclast, as I told you, under the influence of mostly by PTH and calcitonin. Here the absorption basically mediated by the vitamin D. So basically three important hormones are responsible for the maintenance of the calcium balance: parathyroid hormone, calcitonin, and vitamin D. And three important organ: one is intestine, second is bone, and third is kidney. So three hormone, three organ maintains the calcium balance. Now the calcium level is maintained within the very narrow range of 8.5 to 10.5. Now this is the laboratory reference range. If you look into this reference range and its changes over the years, you will find that this level goes up a little bit during the pubertal period from 10 years to 20 years, when we can expect the calcium level may be more than 10 or can go up to 10.7 or 10.5. But above the age of 40, the calcium level should be in the 9s and not in the level of 10s. So anybody above the age of 40 come to you with a serum level of calcium more than 10, especially if it is more than 10.2, be careful that you are not missing a case of hypercalcemia or primary hyperparathyroidism. So therefore, be very careful about the calcium level. The laboratory reference range 10.5 is absolutely right, as far as if this value can goes in the age range of 10 to 20 or 30, but this 10.5 is absolutely out of range if your age is more than 40. Now this skeletal system is a very important role as far as the calcium metabolism, which I have already told you. And in the skeletal part, we have the cortical bone, but the cortical bone actually gives the strength to the bone. It is just below the periosteum. And we have the trabecular bone or the cancellous bone, which is inside. The weight of the cancellous bone is not much. The cortical bone consists of the 80% weight of our skeletal system, but it is the trabecular bone which is basically the metabolically active, and therefore this area is the area which actually have more impact as far as the calcium metabolism is concerned. Now, I have told you that the bone is basically under constant process of remodeling under the influence of the osteoblast and osteoclast. Osteoblast build the bone and osteoclast resorb the bone. So these two cells actually maintains the bone remodeling process, which occurs continuously from every day, from our very day after birth to up to the level of our death. Now these two cells is basically under the influence of many factors. I have told you about the parathyroid hormone and the calcitonin, but they are also under the influence of estrogen, androgen growth hormone, and glucocorticoid, and many other factors. So all these factors influence the bone remodeling, and so therefore has got an influence in the bone strength. I think that has got an influence of development of osteoporosis or osteoporotic disorders. Now, as I've told you that the bone turnover is occurring from the birth up to the death, but in the young years, the formation is slightly more than the resorption. So the skeletal mass grows, and in the middle age, the formation and the resorption is equal. And when after certain age, say for example 40 or 50 or 60, that the resorption process is more than the formation, and gradually the skeleton becomes weak, fragile, and there is an increase in the chance of fragility fracture, which occurs more in case of women, but rather in women it occurs 1 decade earlier compared to the men counterpart. So the three hormones which are involved in the calcium metabolism, one is the parathyroid hormone, another is the vitamin D, So vitamin D is produced by the skin and it is converted into liver to 25 hydroxycholecalciferol, and then in the kidney it is converted to 125 dihydroxycholecalciferol. And this 125 dihydroxycholecalciferol is the active vitamin D, which is responsible for the intestinal calcium absorption. So this is the process. So if a patient has got a liver disorder, we cannot treat the patient with cholecalciferol because the patient will not be able to convert it to 25 hydroxycholecalciferol, and therefore you have to treat the patient with 25 hydroxycholecalciferol or 125 dihydroxycholecalciferol. If the patient has got a renal disease, we cannot treat the patient with cholecalciferol because it will be converted 25, but it will not be able to convert it to 125 dihydroxycholecalciferol. Therefore, in the renal disease, you have to treat the patient with 125 dihydroxycholecalciferol, and that is why in liver disease and kidney disease, our approach to the vitamin D deficiency and the management is different with that of the other patient who do not have this liver or the kidney disease. Now, please remember, in majority of the situation, we treat with vitamin D3, and we should not treat the patient with 125 dihydroxycholecalciferol because it is the active hormone, and therefore there is a possibility of development of hypercalcemia. So, how much vitamin D we need? And this is about the guideline which actually published a long back, but there is no any change after that. So we actually have to maintain the concentration roughly around 28 to 32 nanogram per ml, and therefore to maintain this amount of serum 25 hydroxy vitamin D, we have to give roughly around 1000 international units of vitamin D per day, and possibly that is sufficient enough to maintain the normal serum concentration of vitamin D. So therefore, if you want to give a calcium and vitamin D supplementation to a person, we have to give 1000 milligram of calcium and you have to give 1000 international unit of vitamin D in most of the situation. Now coming to a little bit of the parathyroid hormone, you can see that the parathyroid hormone is basically secreted under the influence of this calcium. If the calcium level is low, look into the green part. If the calcium level is low, the parathyroid hormone level is high. If the calcium level is high, the parathyroid hormone level is low. So this is the normal relationship between the calcium and parathyroid hormone. So if you find that the calcium level is low and parathyroid hormone level is high, it is an appropriate rise of the parathyroid hormone, because calcium is the strongest stimulus for the parathyroid hormone release. Low calcium, high release of parathyroid hormone, and high calcium will suppress the parathyroid hormone release. So therefore, if you find that the calcium level is low, high, but parathyroid hormone level is high, it means the patient has got a primary hyperparathyroidism, because even though the calcium level is high, parathyroid hormone is not suppressed. It is supposed to be suppressed, but it is not suppressed. So therefore, high parathyroid hormone level and high calcium indicates that the patient has got a hyperparathyroidism. Parathyroid hormone not only maintains the calcium, but parathyroid hormone has got a strong phosphatidic action. So therefore, when you give parathyroid hormone, there will be a rise in calcium. There is a decrease in the serum phosphate level as well. Calcitonin, on the other hand, has got a much less influence on the remodeling process at the level of the bone. It has got basically action at the level of the osteoclast. It inhibits the osteoclastic activity, and therefore it inhibits the bone resorption process. Whatever maybe it is, its action is actually weak, and basically parathyroid hormone has got a very strong influence as far as the calcium and as far as the bone metabolism is concerned. Normal level of calcitonin is 10 to 20, and it has got a some effect at the level of the kidney and intestine as well, but it mostly it has got an influence at the level of the bone that inhibits the osteoclast and therefore the bone resorption. So therefore the three hormone, three organ. Now the whenever the calcium level goes up, what will happen? It will actually suppress the PTH, and it will actually, yeah, it will actually, what will happen, that it will release the calcitonin. It will influence the calcium to go inside the bone. It will decrease the calcium uptake by the intestine, and there is a decrease in the calcium resorption from the urine. On the other hand, if the calcium level goes down, then the parathyroid hormone is secreted, which actually releases the calcium from the bone. It increases the resorption of the calcium from the bone, increases the calcium absorption by the kidney, not by direct action, but by indirect action, because it influences the vitamin D metabolism. It has got significant influence at the level of the kidney as well, and it increases the calcium reabsorption from the kidney, and it also has got some phosphoturic action, as I've told you. With this idea in our mind, let us have a look into the cases which I have seen in the last 2 decades. Now, this is Miss 8076, a female admitted with progressive dyspnea for the last 3 months. There was crepitations on the left side. Shape of the chest was altered. She had pneumonitis in the left with pleural effusion. She recovered with IV antibiotic classics and nebulization. So I'm not going into that part of the treatment, but you can see that she had a bow spine. So as because there is a deformity at the level of the spine, so we asked for an radiological evaluation. So you can see there is a definite deformity at the level of the spine, and this will show that there is a significant osteopenia at the level of the spine. So we looked into the pelvis, and the pelvis X-ray showed that there is again a deformity at the level of the pelvis. It appears that the pelvic bone is soft, and it actually deformed because appears to be because of some pressure. Now we have evaluated this patient on laboratory, and you can see that this patient has got a low calcium and high alkaline phosphatase. Now when we find these two important findings, it indicates that there is something wrong at the level of the calcium and vitamin D metabolism. So if we look into the causes of the elevated alkaline phosphatase, you will find that the vitamin D deficiency is an important cause. This is not a case where we can consider the first two. This is not a patient did not have the bile duct obstruction or seminoma. She had no any recent history of fracture. So therefore, the vitamin D deficiency is basically remains to be the only cause as far as the elevation of alkaline phosphatase is concerned. So we have checked her vitamin D level, and as well as we have checked the PTH hormone, magnesium, and repeat the calcium and alkaline phosphatase, which again confirm that there is a low calcium, high alkaline phosphatase, very low vitamin D, and high PTH. So therefore, the diagnosis is that this patient has got a osteomalacia with secondary hyperparathyroidism. So this rise of parathyroid, as I've told you, is because of the hypocalcemia. It is not a case of hyperparathyroidism. It is a secondary hyperparathyroidism. Now, as I've told you that if the low calcium is there, there is a high parathyroid hormone. So high PTH is a secondary. So in a patient with low vitamin D, we expect an increase in alkaline phosphatase, low calcium, and high PTH. Now, what is the diagnostic criteria of osteomalacia? Now, we have taken it from the up to date. You can see that the alkaline phosphatase is elevated in almost 100% cases. PTH is elevated in 100% cases, and low vitamin D you will find in 100% cases. But you may not get a low calcium and low phosphate in all patients. So therefore, the diagnosis mostly depends on the elevated alkaline phosphatase, low vitamin D, and high PTH level. Now, how we treat the osteomalacia? You can see that the treatment is basically replacing the patient with calcium and the vitamin D. Now, there are many ways by which we actually can replace the vitamin D. So we may start with this 50,000 international unit orally once per week for 6 to 8 weeks, and then 800 units daily thereafter. So this is one of the guidelines. In the malabsorptive state, you have to give much higher dose, so 10,000 to 50,000 unit. And as I've told you, in the liver disease, we have to treat the patient with calcidol, means 25 hydroxy D, or calcitrol, 125 dihydroxy D. So to bypass the metabolic process of the liver, if we and we cannot give this patient with oral cholecalciferol. Now, the target 25 hydroxy D level is basically a matter of debate. Even today we don't know, because there are guidelines to guideline this changes. But in majority of this situation, we try to keep it in at the level of 30. But if the patient has got some bone disorder, we'll try to keep it between 30 to 40. Now, in case of growing children and pregnant women, it may be a little bit less. It hardly matters. But we do not have much clinical data or evidences to fix that what should be the ideal target as far as different situations are concerned. Now, when you are using vitamin D, nowadays it is said that it has got a lot of other action apart from its effect on the osteoporosis, bone, and calcium metabolism. So the many studies have shown that it can decrease the pancreatic cancer, can decrease the prevalence of type 1 diabetes, can decrease heart attack, hypertension, but I don't know that whether the evidences are strong enough to use in our day-to-day clinical practice or not, because the guideline has not given this has not given much importance as far as the regular use of this drug to reduce the type 1 diabetes or to treat a patient of hypertension. But nowadays we have the COVID epidemic, and you can see that the use of vitamin D may be associated with significant reduction in the influenza epidemic. And that is why, though, because the vitamin D is not a very drug which can cause a lot of side effects, so we can use this drug at this point of time when we are facing the influenza epidemic. But the evidences and the guidelines in favor of all these effects of vitamin D is not very strong. Now, coming to the other way by which we can treat, as this is another treatment option, is that you can give 60,000 unit, because now we do not have 50,000 unit of vitamin D available in our country. So therefore, we can use the 60,000 international unit of vitamin D once in a week for 8 weeks, which we traditionally give. And then the maintenance therapy of 1,500, 2,000 international unit per day. But in patient those who are obese, who have malabsorption, and the patient those who are receiving anticonvulsant and antitubercular medication, especially the rifampicin, these patients should receive a higher dose, because there is a malabsorption, and there is a possibility that the vitamin D metabolism is affected because of the anticonvulsant therapy or rifampicin. Now, vitamin D you can give it in a nanoparticle formation also, because it will improve the absorption. It increases the bioavailability of vitamin D3, and thirdly, you don't have to give it along with some fatty preparations, because majority of other conventional vitamin D you have to give along with the meal or with some fat, so that it can easily be absorbed. So a nanoparticle formation do not require this kind of prerequisite as far as the administration is concerned. Now, coming to my second case, this is a 66-year-old lady, was admitted in 2010 with history of repeated convulsion and carpopedal spasm. She has repeated muscle cramps for the last 3 months. She is hypothyroid for 1 year and was on levothyroxine therapy. She had a history of unconsciousness 6 months back. And now, when we look into the lab parameters of this patient, she already had some of the lab reports available with her, which showed that she definitely had hypoparathyroidism, for which she was getting treatment, levothyroxine therapy. And if you look into the lab parameters, you find that there is a low calcium and high alkaline phosphatase, indicating possibly we are dealing with a patient with vitamin D deficiency. But another important issue which actually little bit odd in front of us was the basal ganglia calcification, because she had the history of convulsion. She underwent a CT scan and it showed the basal ganglia calcification. The issue is that the vitamin D deficiency is not associated with basal ganglia calcification. Now, we have re-evaluated this patient further, which actually showed that there is a low calcium, high alkaline phosphatase, IPTH is high, vitamin D is low. So it means the diagnosis is confirmed. There is hardly any skeletal changes, not much skeletal changes, but the patient has got vitamin D deficiency, significant vitamin D deficiency, with hypocalcemia, with rise in alkaline phosphatase, with secondary hyperparathyroidism, but with basal ganglia calcification. Now the issue is hypoparathyroidism is often associated with basal ganglia calcification, but we do not have much idea whether the vitamin D deficiency can have basal ganglia calcification or not. So we looked into the literature and it showed that some kind of mutation, SLC20A2 mutation, may be associated with primary brain calcification quad disease, which sometimes associated with hypovitaminaceous D. So this may be, there are some case reports available, that's it, and that may be a possible explanation of the presence of vitamin D deficiency along with basal ganglia calcification. This is RC 74 years female, admitted in the pain in the back and inability to move. She had a history of fall from chair recently, and she also had a fall in bathroom 10 years back. Now she was on omeprazole for 10 years, over-the-counter medication. She is a lean elderly lady and she had some spine tenderness, and you can see that the back was slightly bent or kyphosis. And when we have done the X-ray evaluation, you can see there's a multiple vertebral fracture. You can see that the height of this spine and height of this spine and height of the body of the spine. Now you can see that this is quite and this is quite smaller. This height is quite smaller, indicating there is a compressive fracture. So this patient has got a multiple vertebral fracture. So that possibly is because of osteoporosis. But often the patient, those who have osteoporosis, can have a superadded vitamin D deficiency and osteomalacia as well. It is not very uncommon. So we have looked into the biochemical finding. As you know, that in case of the osteoporosis, the patient have got no abnormality in the biochemical evaluation. So we do not expect hypo or hypercalcemia among patients, those who have primary osteoporosis. But you can see this patient has got an osteoporotic fracture, multiple vertebral fracture, but this patient has got a low calcium, high alkaline phosphatase, very low vitamin D, indicating that we are dealing with a vitamin D deficiency disorder as well. Now the issue is this patient has got a normal IPTH. It is inappropriately normal. We are expecting that the PTH level should be high because the calcium level is low, so the PTH level should be high. But in this particular patient, the PTH level was not high. So to summarize the patient, we have osteoporotic multiple vertebral fractures. We have low serum calcium, raised alkaline phosphatase, low vitamin D3, low urinary calcium excretion, but inappropriately normal IPTH. So therefore, you can see if a patient has got a low calcium, and if you find that this patient has got a low PTH or inappropriately normal PTH, so we have to search a cause of the low PTH. Why this patient have low PTH? So that should be the way by which we should approach into this patient. Now, what are the causes of the low PTH? Possibility is that are we dealing with an idiopathic hypoparathyroidism? The second is magnesium. Low magnesium is responsible for the low PTH level because magnesium is required for the PTH secretion. And third is whether the PTH has degraded on the transport. So we have drawn the sample, we have sent the sample to the laboratory, which took some time because we could not do the sample in-house. So we had to send the sample outside, and possibly there may be some degradation of the pH on the way during the transport process. So the easiest one among these three is to evaluate the magnesium. So we have checked the magnesium level, and magnesium level came 0.8. So how we'll treat this patient? We have to replace the magnesium. So unless and until we replace the magnesium, we'll never be able to correct the calcium level. So therefore, the magnesium replacement is equally important, rather more important than the correcting the calcium value. As you know that calcium and magnesium are basically the intracellular ion, and therefore the one deficiency of one is often associated with deficiency of the other. Now we have to treat this patient with 1 to 2 gram of magnesium sulfate, 50 to 100 ml 5% dextrose over 5 to 60 minutes time, and then we can give an infusion which should be continued for 1 or 2 or 3 days, because magnesium, as I told you, is an intracellular ion. So when you find that the serum magnesium is low, then there is a significant depletion of the intracellular magnesium also, and therefore you should continue with the therapy for a few days, because we have to replete the intracellular deficit as well. So we have to make a target plasma magnesium level of above 1 milligram per DL. In patients those who have renal impairment, which is also an important cause of magnesium deficiency, the replacement may be higher. Now the oral tablets or oral capsule or oral replacement is not available in our country. Only 1 or 2 brand is available as far as the oral magnesium preparation is concerned, and very hard to get. So in most of the situation, we actually treat the patient with IV magnesium. In this particular patient, we have treated with 2 ml IV infusion 8 hourly for 5 days. We have given the oral calcium, and we have corrected vitamin D by giving oral vitamin D tablets. Now, why this patient had hypomagnesemia? Then the next question. So we looked into the cause of hypomagnesemia, and you can see that one of the important cause of hypomagnesemia is the long-term use of the proton pump inhibitor. And if you can recall, this patient was receiving the omeprazole for the last 5 or 10 years, and that possibly is the cause of magnesium deficiency in this particular patient, because this patient has got no history of diarrhea, no history of alcohol use, uncontrolled diabetes, transplant, and renal disease. Renal disease or chronic renal disease often associated with urinary loss of magnesium. So the final diagnosis is osteoporosis with vertebral fracture, vitamin D deficiency, and hypomagnesemia. Now, if we look into the etiology of the hypokasmia, we should always do an PTH. If you find the calcium level is high, check PTH. If you find calcium level is low, check PTH. So therefore, whenever there is a calcium level abnormality, my second course of action is to look into the PTH. Now you can see that if there is an hypocalcemia, and if you find there is a high parathyroid hormone, then the vitamin D deficiency is the one and most important factor or most important cause of this particular association, hypocalcemia and high parathyroid hormone, as I showed you in different cases. Now the other causes of hypocalcemia and high parathyroid level can occur in the chronic disease. This is basically a secondary hypoparathyroidism, and can occur in some rare causes. But the commonest cause of hypocalcemia with high PTH is a vitamin D deficiency in our setup. Now, hypocalcemia can occur with low PTH. Now, when there's a low PTH, we have to think about hypoparathyroidism, which can be caused by surgical hypothyroidism, or by acquired hypoparathyroidism, or by polyglandular autoimmune syndrome. So therefore, let us come to the patient, those who have hypocalcemia but have low PTH value. Now, this is a patient, 37-year-old lady, was detected papillary carcinoma of thyroid in 2011. She underwent total thyroidectomy in June 2011, 3 days after her operation, she developed the paresthesia in the upper limbs and lower limbs. This is very common after the total parathyroid surgery and is very easy to diagnose. So in most of the situation, it is because of hypocalcemia, and as you can see that this patient has got a low calcium 7.4 and the normal vitamin D, and you can see the inappropriately low pTH. So we expect that when there is a low calcium, the pTH should go up, but here the pTH has not gone up. It is basically inappropriately normal, and this is a classic finding when we have a patient with total thyroidectomy. Now the issue is, in most of the situation, this hypocalcemia is basically transient. So therefore, hypocalcemia can occur in 1/3 of the cases after total thyroidectomy, and even it may start inside the OT after the removal of the thyroid and thyroid gland. Now there is a substantial decline in pTH occur before the patient leaves the operating room. Many patients are found to have reached a nadir of calcium level at 48 hours or beyond. pTH concentration obtained at 6 hours after thyroidectomy has got a very predictive value as far as the calcium replacement therapy is concerned. Most patients recover within 2 weeks period of time. So therefore, they will not require the supplementation of the calcium for a long period of time, because most of the cases, the surgeons are very particular as far as preservation of the parathyroid gland is concerned. Sometimes in some rare cases, even though they try to preserve the parathyroid gland, there is a substantial destruction of the gland because of a surgical process, and that can lead to permanent hypothyroidism in some few cases after total thyroidectomy. Now, permanent hypoparathyroidism, if diagnosed, if the patient has got, the patient is taking the replacement therapy or supplementation of vitamin D and calcium for more than 6 months. Otherwise, most of the case reverse back within 2 weeks period of time, and some of the patients require a longer vitamin D and calcium supplementation up to the level of 6 months. So if you look into the pTH value, that can give you some idea what you are supposed to do. If the pTH value is more than 20, don't do anything, no supplementation is required. If the pTH value 10 to 20 after the surgery, then you have to supplement with calcium, and you should gradually taper the dose after 2 weeks, because possibly this particular individual will not require the supplementation after 2 weeks. And if the pTH value is less than 10, you have to supplement with the calcium and calcitriol, but you have to recheck after 2 weeks to see whether the supplementation should be required further or not. Now this is another case of 22-year-old boy who came to me in long back, and he developed thalassemia at 9 months of age, and blood transfusion started at 1.5 years of age, and he used to receive roughly around 4 units of blood per month. He was regularly on deferriprone, 500 milligram, 5 tablets, and even with the scale for therapy, his serum ferritin level went above 10,000 nanogram per dl in Jan 2005, and since then he was receiving the deferoxamine desperal 2000 units subcutaneously repeatedly. He had a history of convulsion in 2001, and his EEG showed non-specific changes, and since then he was started with the Gardiner and Luvazan. Now, this patient admitted in 2005 with fever, throat infection, several episodes of muscle cramps and generalized body ache, and he was flushed with had an hepatosplenomegaly with no local muscle tenderness or limbs, but had a positive Trousseau sign, but he had no other neurological deficit. So we looked into the lab parameter of this patient, and you can see that the calcium level was very low at the, when he was admitted in 2005, but the alkaline phosphatase was 86, indicating that possibly we are not dealing with vitamin D deficiency, because in case of vitamin D deficiency, as you know, that the alkaline phosphatase should go up. but the calcium value is very low, 3.8, and that is a possible reason of this Trousseau sign and the muscle tenderness and the generalized body weight and muscle cramps. Now we have rechecked the calcium, magnesium, IPTH, and vitamin D, and you can see vitamin D is normal, IPTH is very low, 2.5, and magnesium was also very low, and calcium very low. So what will be our approach? We should start the magnesium and calcium replacement simultaneously. So we have started magnesium and calcium replacement, and we monitored the calcium and phosphate and magnesium regularly, and you can see this monitoring report. And on the day 8, you can see that we have almost corrected the magnesium value, 1.14, 1.09. It is corrected, but even though the magnesium level has been corrected and it remained corrected for the last 3-4 days, but the calcium level remains 6.67. But even with a low calcium value, the PTH level is normal or inappropriately normal. So therefore, what we were expecting that a patient, those who have magnesium deficiency, if we correct the magnesium deficiency, parathyroid secretion should be normal. And therefore, the parathyroid gland should respond normally. So parathyroid gland should, if the parathyroid gland is supposed to respond normally, then the low calcium value should have a high PTH value. But this patient did not have a high PTH value, indicating that we are dealing with hypoparathyroidism as well. So muscle cramp and pain gradually improved. IV calcium magnesium replacement gradually stopped on day 6. Oral calcium and oral magnesium started. But even then, the IPTH was inappropriately low. So oral calcium and calcitriol with the diagnosis of hypoparathyroidism was started. No further seizure, and was discharged from the hospital, and anticonvulsant was gradually withdrawn over the 6-month period of time, indicating that initial anticonvulsant was given, and initial convulsion or whatever maybe the history was there, but possibly triggered because of hypocalcemia, and that actually possibly precipitated because of hypoparathyroidism. Now, in the patient of thalassemia, lot of endocrine organ can get damaged because of the iron overload, and you can see that the transfused RBC is one of the responsible factor for this endocrine organ damage, and chronic hypoxia is also responsible for the endocrine organ damage. And this patient actually had hypoparathyroidism in patients with transfusion-dependent thalassemia, and we have actually published this paper. Now, my last case is this one, the master age 17 years aged boy who had recurrent fever since February 2010, which used to subside on taking paracetamol, no history of weight loss, no loss of appetite. A battery of tests done because of the fever. So that was his concern. So ultimately, low calcium and pulmonary tuberculosis was detected, and anti-tubercular drug was started. He started improving, discharged from the hospital with anti-tubercular drug and calcium supplementation. The issue is why this patient had a low calcium was not evaluated. Anyhow, if we look into the drugs which can cause vitamin D deficiency, one of the important drug is rifampicin. Another I have told you is anti-epileptic, the phenytoin carbamazepine, what we commonly see, though the dexamethasone, prednisolone, and nifedipine spironolactone also can cause vitamin D deficiency, but the anticonvulsant are notorious as far as the development of vitamin D deficiency and hypocalcemia is concerned. Anyway, because this patient has got a hypocalcemia, the addition of rifampicin can actually potentiate the hypocalcemia further. 4 days after his discharge, the parents noticed that he was not responding well, talking and crying irrelevantly, stiffness of the body, and remained in awkward posture for long duration, and was suspected to have catatonia. Cannot voice his daily needs and was always fed by the caregivers. CT scan of the brain was done, referred to psychiatrist, diagnosed to have schizophrenia, and antipsychotic medication was started with risperidone and pacitine. Anti-tubercular drug and calcium supplement continued, psychosis improved, and patient became calm, but why this patient had hypocalcemia was not evaluated. Now in June 2010, he was referred. He did not have any such episodes, further completed his intensive phase of anti-tubercular drug and now on rifampicin and INH. Fever subsided, slept normal, everything was normal, and there was no water, but he had Trousseau sign positive. So the physician referred this patient for the evaluation of the hypocalcemia, and you can see that the calcium level was done repeatedly. It was basically low with a normal serum albumin level, and this patient has got a high TSH and positive anti-TB antibody. So it indicates that the patient has got a low calcium and the patient has got a subclinical hypothyroidism, possibly of autoimmune origin. So the CT scan was done as because the patient had the convulsion, history of convulsion, and we found that there is a calcification, bilateral extensive calcification of basal ganglia. Now the calcium level was 8.3, it was repeated, magnesium was normal, IPTG is 12.5, indicating that we are dealing with hypoparathyroidism, low vitamin D normal. So low calcium, low vitamin D indicates that low calcium, normal vitamin D, and normal IPTH value or low IPTH value indicates that we are dealing with a hypoparathyroidism. So this patient has got a primary hypoparathyroidism and subclinical hypothyroidism, possibly of autoimmune disease. Now, if you look into the causes of the hypoparathyroidism, why this patient had hypoparathyroidism? Now, if you look into the causes of hypoparathyroidism, you will find that the parathyroid gland abnormality occurs in children. This occurs all in young age patient. Surgical is a very common cause, rather the commonest cause of hypoparathyroidism, which we have already discussed. And I have already discussed about the infiltration of the parathyroid gland because of the iron overload, which is basically the acquired hypoparathyroidism that can occur. And lastly, we can have autoimmune cause of hypoparathyroidism, and sometimes the multiple autoimmune disease may be present simultaneously. Now, we're looking into this into the case. This patient was on anti-tuberculosis drug because of pulmonary tuberculosis, psychiatric behavior because of ionic psychosis, hypokasmia. Either of these two is possibility. Hypothyroidism with positive anti-TB antibody indicating at autoimmune disease. There is hypokasmia and basal ganglia calcification, and primary hypoparathyroidism responsible for the basal ganglia calcification. And in the mouth, I'm sorry for the poor quality of the picture, but this patient has got a mucosal candidiasis, oral candidiasis. So we looked into the serum cortisol value of this patient because we suspected this patient multiple endocrine autoimmune disorder, because this patient has got one autoimmune disorder of hypothyroidism, the suspected an autoimmune primary hypothyroidism. So we looked into the autoimmune adrenal insufficiency, but this patient had a normal cortisol at 9 a.m. So if you look into the polyglandular autoimmune syndrome, you will find the polyglandular autoimmune syndrome type 1 is associated with mucocutaneous candidiasis, hypoparathyroidism, and adrenal failure. Presence of any two of the three actually makes the diagnosis. So therefore, this patient had mucocutaneous candidiasis, hypoparathyroidism, and an autoimmune thyroid disease, indicating that possibly we are dealing with polyglandular autoimmune syndrome. So we treated this patient with levothyroxine therapy, calcium, calcitriol, with continued anti-tubercular drug. Antipsychotic drug stopped and gradually withdrawn without any untoward effect, because it all was hypocalcemia was responsible for all kind of problem, and we continue with the pyridoxine. So take home, number one is the measure albumin level while you are measuring the serum calcium. We have to consider the serum calcium concentration with respect to the serum albumin level. Now, the serum calcium value is maintained within a very narrow range of 8.5 to 10.5, but if it goes in the range of 10.5 among the patient whose age is more than 40, be careful about not missing primary hyperparathyroidism. Almost all subjects with osteomalacia have elevated alkaline phosphatase, elevated PTH level, but may have normal serum calcium and phosphorus. You should always check magnesium in patient with hypocalcemia when PTH is inappropriately normal, because magnesium is one of the very important ion responsible for helping the release of the PTH from the parathyroid gland. Overt hypoparathyroidism can rarely occur in thalassemia subjects, not very common, but can occur. Polyglandular autoimmune syndrome type 1 is associated with hypoparathyroidism and mucocutaneous candidiasis. And thank you very much for your patient listening.